In this video, I will be talking about elimination half-life of a drug. The overview of this presentation will include the definition of half-life and understanding the concept of half-life with the help of one compartment and two compartment models, the calculation of half-life and the factors regulating half-life. Thirdly, how is half-life related to the steady-state plasma concentration of the drug and the elimination rates of the drug. And lastly, the clinical significance of half-life. Half-life in the context of medical science refers to elimination half-life of the drug. Half-life is defined as the time taken for the plasma concentration of the drug to reduce by 50% of the earlier value. It is also known as elimination half-life of a drug. So let us assume the plasma concentration of the drug to be 100 units. So in 1 T half, the plasma concentration reduces by 50% and the concentration is 50 and 50% of the drug is eliminated from the body. In 2 T halves, the plasma concentration is reduced by half and the concentration becomes 25. The percentage of drug eliminated is 50 plus 25, that is 75% of the drug is eliminated from the body. In 3 T halves, the plasma concentration is further reduced by half and the concentration becomes 12.5. The percentage of drug eliminated from the body is 50 plus 25 plus 12.5, that is 87.5% of the drug is eliminated. In 4 T halves, there is further reduction in plasma concentration by 50% and 93.75% of the drug is eliminated from the body. So 4 to 5 T halves are required for complete elimination of drug from the body. So let us understand the concept of half-life with the help of one compartment and two compartment model. The one compartment model is a simplistic model of human being and consists of a central or the vascular compartment into which a Q amount of drug is introduced into the compartment by intravenous injection. The drug is distributed in the vascular compartment and is later removed from the compartment with the help of metabolism and excretion. In two compartment model, there is a peripheral component which has extravascular tissues, that is the vascular tissues, the adipose tissue and the muscle. Initially, when the drug enters into the compartment, the plasma concentration of the drug is high. Subsequently, the drug distributes into the extravascular tissues and this is seen as a rapid decline in plasma concentration and this is due to distribution. Later, the drug diffuses back into the vascular compartment and is slowly removed by elimination. So this is seen as a slow decline in plasma concentration and this is due to elimination. So the rapid decline in plasma concentration is due to distribution and slow decline in plasma concentration is due to elimination. So when we calculate T half is a dependent variable and it depends on the volume of distribution and clearance. So it is directly proportional to the volume of distribution and inversely proportional to clearance. Since the T half is directly proportional to the volume of distribution, if the volume of distribution is high, it means that more amount of drug is deposited in the extravascular tissues which is slowly released into the vascular compartment and so the elimination half-life of the drug will be high. Half-life is inversely proportional to clearance, which means that if the clearance of the drug is high, that is it is removed from the body quickly, the T half decreases. So if clearance is high, the elimination half-life will be low. And if clearance is less, there is accumulation of drug in the body and this will prolong the half-life of the drug. So T half is directly proportional to the volume of distribution and inversely proportional to clearance of the drug. For example, in obesity, where the individuals have large amount of adipose tissue and majority of the drug is distributed in the adipose tissue and is slowly released into the vascular compartment. So this prolongs the duration of action of the drug. In situations where there is presence of pathologic fluid, for example, pleural fluid, pericardial fluid, where the drug drug gets deposited in the fluid and is slowly released into the vascular compartment, and this prolongs the half-life of the drug. Next, we move on to clearance. When the clearance of the drug is high, for example, induction of cytochrome P450 enzymes, which enhances the rate of metabolism of the drug, and due to increased metabolism, there is increased clearance of the drug, and increased clearance decreases the plasma half-life of the drug. On the contrary, if the cytochrome P450 enzymes are inhibited, there is inhibition in the hepatic metabolism of the drug. This leads to increased accumulation of the drug and prolongation of half-life. Half-life is also influenced by organ failure. In cases where there is decreased blood flow to organs such as liver, kidney and heart, the failure of the organs decreases the blood flow to various organs and tissues, and this decreases the clearance of the drug, leading to accumulation of the drug and prolongation of half-life. So how is half-life related to the steady state plasma concentration of the drug? On administering a drug at regular intervals and at a constant amount, initially the plasma concentration of the drug is high. This is because the entry of the drug is greater than the rate of elimination of the drug from the body. So the plasma concentration of the drug rises, and if the drug follows first order kinetics, the rate of elimination is directly proportional to the plasma concentration of the drug. So if the plasma concentration rises, the rate of elimination also increases. So after 4 to 5 t-halves, a steady state concentration of the drug is achieved. And this is the state at which the drug entry is equal to the rate of elimination of the drug. And this is the point at which there is no further accumulation of the drug with repeated doses, and the plasma remains at the steady state concentration. Now, after the steady state concentration is achieved, the drug is eliminated from the body by 4 to 5 t-halves. The steady state concentration is dependent on dosage, dosing interval and clearance of the drug. When it comes to dosing regimens, when the total quantity of drug remains the same average steady state plasma concentration is achieved with different dosing regimens. So what are the different dosing regimens? The dosing regimens can be in the form of continuous regimens and discontinuous regimens. So continuous regimens as in continuous IV infusion, which represents a smooth curve, and the steady state plasma concentration is very smooth, whereas discontinuous dosing regimens can be in the form of small frequent doses and infrequent large doses. So this results in peaks and troughs above and below the target drug concentration, and sometimes the peaks and troughs are too large that it falls above and below the boundary of the therapeutic window, resulting in therapeutic failure. Frequent small doses results in small fluctuations in the plasma concentration of the drug, and the plasma concentration remains within the therapeutic window, whereas with infrequent large doses, there is a sharp spike in the plasma concentration of the drug with a large dose, and since the dosing interval is long, the concentration of the drug falls below the boundary of the minimum effective concentration, and this can lead to therapeutic failure. So this is why frequent small doses are more efficacious and better tolerable than infrequent large doses, where the peaks and troughs may cross above and below the boundaries of the therapeutic window, and this can lead to toxicity or therapeutic failure. We next move on to the clinical relevance of half-life. Half-life is clinically relevant when the physician must determine the most efficient yet the safest dosing schedule. So how does the physician decide the dosing schedule? For drugs which have a very short half-life of 1 to 5 minutes, for example norepinephrine, dopamine, oxytocin, these drugs are given by constant IV infusion. Drugs which have a short half-life of 30 minutes to 2 hours, it would be inconvenient to administer the drugs at every half-life. In such cases, provided the safety margin of the drug is high, A large dose of the drug can be administered so that the drug can be administered at 6 to 8 hourly interval. Drugs which have a long half-life, for example, chloroquine 1 week, amiodarone 1 month, so it would take a very long period to achieve a steady state plasma concentration. So for such drugs, a loading dose is administered to achieve the steady state plasma concentration quickly. Next, half-life can also show if accumulation of the drug is likely with the multiple dosing regimens. Next, half-life also helps the physician in making dose adjustments in situations of drug toxicity. Drug toxicity can arise from drug overdosage, from incorrect administration of the drug, and in organ failure. So T-half is a useful parameter as it gives an accurate indication about the length of time the drug persists in the individual.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.